Welcome to the deep dive. Today, we're digging into something pretty specific but really important in vascular surgery, infrainguinal bypass.
That's right. It basically a way surgeons create a new path for blood flow when the arteries in the lower legs or feet get blocked or narrowed.
And we're going deep. We're pulling our info straight from, well, the definitive source, Chapter 112 of Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
Yeah, this isn't just surface level. Rutherford's is, the textbook for vascular surgeons. So we're tapping into some serious expertise on how they surgically treat this infrainguinal disease.
Exactly. Think of this as your fast track to really understanding this operation. We're aiming to pull out the key stuff, the why, the how of planning and doing it, the big choices involved, and what kind of results people can expect.
We want to make it clear, give you those aha moments.
Yeah.
Without drowning you in technical terms, you might even find a few surprising details along the way.
Okay, let's jump in. First things first. Why would someone actually need this kind of surgery? What are the main reasons?
Well, the chapter really points to two main drivers. First, there's chronic limb-threatening ischemia, CLTI for short, and second, something called disabling claudication.
Claudication, that's the pain usually in the calf when you
Yeah.
walk or exercise, yeah.
Exactly. But for bypass surgery to even be considered just for claudication, it has to be really impacting your life significantly. We're talking limiting your job, your hobbies, just your daily comfort.
So it's not just a little bit of pain.
No, no. And importantly, the chapter stresses that you'd always try non-surgical stuff first, stopping smoking, getting into an exercise program, medications,
Right.
and the risk of claudication on its own leading to really bad outcomes like needing an amputation. It's actually relatively low over, say, 3 to 5 years. Maybe 20% see some deterioration, only about 5% face amputation.
Huh, that's lower than I might have guessed.
It is. And that's why in many specialized centers, bypasses done purely for claudication are actually a minority, maybe only 15 to 30% of their infrainguinal bypass cases.
Okay, so if it's not mostly for claudication, then CLTI must be the big one. That sounds, well, threatening, like the name says.
It really is. CLTI is the more advanced stage where the limb is genuinely at risk. Intervention is usually needed to prevent losing the leg. Historically, we use systems like Fontaine or Rutherford classifications to grade it.
Right, stages 3 or 4 through 6.
Exactly. But more recently, there's been a European consensus defining CLTI based on things like persistent rest pain, pain even when you're not moving that's bad enough to need strong painkillers for at least 2 weeks, and having really low blood pressure readings in the ankle or the toe.
Okay.
Or it could be someone who has ulcers or even gangrene on their foot or toes, combined with those low pressure readings. Or, interestingly, in diabetic patients, sometimes just having absent pulses in the foot is enough to meet the CLTI criteria, along with tissue loss.
Wow, okay. So we're talking constant pain, actual tissue damage. It's serious.
Very serious. And the chapter mentions how our definitions have evolved.
Mhm.
People used to talk about critical versus subcritical ischemia based on amputation risk.
But now there's something newer, YOAI.
Yes, the WIFI classification system, developed by the Society for Vascular Surgery. It stands for wound, ischemia, and foot infection. It grades each of those elements.
WIFI. Got it.
Right, and based on those grades, you get a clinical stage from 1 to 4. This staging actually helps predict the risk of major amputation within a year quite accurately. It's been validated, tested in multiple studies, and it's now part of the global guidelines for managing CLTI.
So WIFI gives a more precise risk assessment, which must really help guide treatment choices. What about GLASOS? The chapter mentioned that too, briefly.
GSA. That's a newer system focused more on the anatomy, describing where the blockages are and how bad they look on imaging.
Okay.
But the key thing the chapter points out is that, unlike WIFI, GS hasn't really been validated yet, specifically for predicting how well an infrainguinal bypass will do. So it helps describe the problem, but WIFI is still the go-to for predicting surgical risk in this context.
Understood. So WIFI for risk prediction before bypass. Now, moving towards the OR, what kind of preoperative assessment is needed? These patients often have other health issues, right?
Absolutely. That's a major point in the chapter. People needing this surgery often aren't just dealing with leg artery problems. Diabetes is common, COPD, lung disease, kidney problems, and especially coronary artery disease, CAD. Heart issues are very prevalent.
Yeah, it makes sense. It's often systemic artery disease. So how do they handle the cardiac risk? Deciding who needs a big heart workup before leg surgery sounds tricky.
It is, and it's been a bit controversial or at least debated. The approach outlined in Rutherford's focuses on, first, getting the patient's existing medical conditions under the best possible control. So optimize blood pressure, make sure they're on the right meds for any chest pain, things like that.
Okay, stabilize what you can.
Exactly. Extensive cardiac testing, like stress tests or even getting heart stents put in before the leg bypass, is generally reserved for patients who show clear signs of instability. Things like unstable angina chest pain at rest, a very recent heart attack, heart failure that's poorly controlled, really severe valve problems like aortic stenosis or serious heart rhythm issues.
So only if there are active, serious heart problems.
Pretty much. The key insight is that if the patient doesn't have those major red flags, the priority often shifts towards getting that blood flow restored to the leg relatively quickly. Delaying the bypass surgery, especially in CLTI cases, can actually increase the risk of complications, including amputation.
So the urgency for the leg can sometimes outweigh doing a preventative heart procedure if the heart seems stable enough.
That's the thinking. The chapter even cites a significant trial that found no benefit from routine cardiac procedures before vascular surgery in patients who are otherwise stable from a heart perspective. So move away from automatic, expensive testing for everyone towards optimizing their current medical care.
That's a really important shift. Okay, what about imaging the leg arteries themselves? What do they need to see before planning the bypass?
Oh, imaging is absolutely critical. You need to know exactly where the blockages are, how extensive they are, and crucially, what the arteries look like above the blockage, the inflow, and below it, the outflow target for the bypass.
And how do they get that picture?
For most patients, the chapter still calls standard arteriography the gold standard. That's where they inject contrast dye and take x-rays.
Still the gold standard, even with CTs and MRIs.
Well, CT angiography, or CTA, is great for larger vessels like the aorta or iliac arteries. But the chapter points out that down in the lower leg, the arteries are much smaller, and patients, especially those with CLTI, diabetes, or kidney issues, often have a lot of calcium buildup.
Ah, and calcium can make CT images hard to read.
Exactly. It can obscure the view. Magnetic resonance angiography, MRA, is getting better and better, and it's a good option, especially for patients who just have claudication. In fact, for some simpler claudication cases, the chapter suggests that a really good duplex ultrasound, that's the specialized ultrasound we mentioned, might even be enough information to plan the surgery. They might just have arteriography ready as a backup to use during the operation if needed.
Interesting. So maybe less invasive imaging sometimes, but for the really critical cases, the CLTI, it sounds like they still prefer that dedicated arteriogram beforehand.
Yes, generally. And for a couple of key reasons. For one, many CLTI patients might actually be candidates for less invasive endoluminal treatments first, like angioplasty or stents.
Right, fixing it from the inside.
Exactly. So doing a diagnostic angiogram separately gives the team time to properly consider both options. Open bypass versus an endovascular approach. And if bypass is the plan, having that detailed angiogram well in advance allows for meticulous planning. The surgeon can review the images, maybe discuss tricky cases with colleagues, and really map out the best strategy before getting into the OR.
That makes sense. Avoids rushing decisions.
Right. Trying to do a full diagnostic study and a complex bypass all in one the one-stop shop idea can be challenging logistically and time-wise. That approach is usually better suited for less complex claudication cases with maybe just one blockage.
Plan the route carefully before you start the trip. Okay, so they have the images. How do they pinpoint exactly where to connect the bypass downstream, the target artery?
The chapter is pretty clear that with good quality angiography, they can almost always find a suitable target artery, even way down in the lower leg or the foot.
Even if the blockage is extensive.
Yes. They mention specific techniques during the angiogram itself to help visualize those tiny vessels better, like warming the foot, using medications to open up the arteries, selectively injecting dye into specific arteries like the SFA or popliteal, especially in diabetics where visualization can be tough. They also describe different ways to get the catheter in place for the pictures, like going from the opposite groin or sometimes directly down from the same side. It's really quite rare, the chapter says, usually only in very complex redo cases, that they truly can't find any target artery on the images.
And what then?
In those very rare situations, they might even need to do a surgical exploration, using Doppler ultrasound findings as a guide, to physically find a usable vessel. But the main message is, lack of a suitable outflow target is seldom the reason someone can't have a bypass.
That's reassuring. Now, the bypass itself needs a tube, a conduit. The chapter really hammers home the importance of using the patient's own vein, autogenous vein. Why is it so much better?
There's universal agreement on this, according to the chapter. Autogenous vein is simply the best material for infrainguinal bypass, period. Doesn't matter if it's above or below the knee.
And the main one they use is the great saphenous vein, the GSV.
Yes, the GSV, it runs down the inner thigh and calf. It's usually the most readily available, and it tends to hold up the best over time. It's the most durable.
And that's why they do that ultrasound mapping beforehand, to check the vein.
Absolutely critical. That preoperative duplex vein mapping is essential. They need to know. Is the vein there? Is it big enough? Generally, they like to see it at least 3 millimeters in diameter, and is it good quality? Soft, compressible, no significant calcium or scarring.
What if the GSV in that leg isn't good?
Then the search continues. They'll map the small saphenous vein in the same leg, check both saphenous veins in the other leg, and even look at veins in the arms, the cephalic and basilic veins.
Wow, they really look everywhere.
They do, because the chapter emphasizes that the type and quality of the conduit in the bypass tube is probably the single biggest factor determining the long-term success of the operation. So finding the best possible vein is paramount.
It's worth the effort. What about how they actually take the vein out? Are there different ways?
Yes, a few techniques. They can make one long continuous incision over the vein, or use several smaller separate skip incisions, or sometimes use endoscopic harvesting small incisions with a camera.
Like they do for heart bypass sometimes.
Exactly. But the chapter notes that endoscopic harvesting hasn't become quite as common for leg bypasses. Maybe due to equipment costs, the learning curve, and maybe some concerns about potential injury to longer vein segments needed for the leg.
Does one method work better long term?
Interestingly, the chapter says there isn't really strong evidence showing one harvesting technique is definitively better than others for the final outcome. The critical thing is the quality assessment. However they get it out, if the vein looks poor quality, they shouldn't use it.
Right.
They talk about an all-autogenous policy. Prioritize using the patient's own good quality vein. Don't compromise on that just for a smaller scar or slightly quicker harvest.
Yeah.
And whether they use the saphenous vein reversed or in its original spot in situ, it seems to work equally well.
Quality vein first, always. Okay, let's get into the operation itself. Planning is key, you said. What are the big strategic decisions surgeons make?
It's definitely strategic. First off, they have to ensure good blood flow into the bypass graft, the inflow. If there are significant blockages higher up in the iliac arteries in the pelvis,
Above the groin.
right, those might need to be fixed first, maybe with a stent during the diagnostic angiogram, or sometimes they do it at the same time as the bypass, a hybrid procedure. The chapter even gives specific pressure measurements, gradients across the blockage, that tell them when an iliac fix is needed for claudication versus CLTI.
Got it. Fix the upstream problem first. What else?
Often, they also need to deal with blockages right where the bypass starts, in the common femoral artery or the deep femoral artery, the profunda femoris, in the thigh.
Okay.
This often involves an endarterectomy, basically cleaning out the plaque from that artery. They might use a patch of vein to widen it afterwards, sometimes called a Linton patch, or even use part of the bypass vein itself as the patch.
Why is cleaning out that area so important?
It's like building in a safety net. The profunda artery supplies a lot of blood to the thigh. If the main bypass graft were to fail later on, having a clean, open profunda can sometimes provide enough blood flow to prevent the leg from becoming severely ischemic again. It's crucial backup circulation.
Ah, a built-in plan B smart. What about the other end? Connecting it down the distal connection or anastomosis?
The main goal is to bypass all the significant disease and connect the graft to the first reasonably healthy artery downstream that has at least one clear path, one runoff vessel continuing down towards the foot.
So connect it above the next healthy segment with an exit route.
Essentially, yes.
Huh.
If the popliteal artery behind the knee is open further down and it connects to at least one open tibial artery going to the foot, that popliteal segment is often the target.
Okay.
But here's something interesting the chapter mentions. Sometimes it can bypass to what's called an isolated popliteal segment.
Isolated, meaning it doesn't connect directly to the foot arteries?
Right. It's a segment of the popliteal, maybe 5 centimeters or longer, that's open itself, but the main arteries below it are blocked. There's no direct continuous runoff. Surprisingly, these bypasses can actually work quite well, especially if the patient doesn't have a lot of good quality vein available for a longer bypass.
Huh. That is surprising.
It is. However, the chapter does add that if the patient has actual tissue loss, like ulcers or gangrene on the foot, they generally prefer to bypass to an artery that does have a direct, continuous connection to the foot circulation if possible.
Makes sense. Get the blood flow as close to the problem area as you can. What if they do need to go lower, down into the calf or foot arteries, the tibial, peroneal, or pedal arteries?
The principle is the same. Find the most proximal, the highest up healthy artery that connects to the foot. If they have enough good vein, a patent anterior or posterior tibial artery that clearly runs to the foot is usually preferred over the peroneal artery, which runs deeper near the fibula bone.
Okay.
But then there's a bit of a debate, particularly for patients with tissue loss. Is it better to target the peroneal artery, which might allow for a shorter bypass, or go all the way down to a pedal artery on the top or side of the foot?
What are the arguments?
Some surgeons strongly favor pedal bypass, especially for diabetics with tissue loss. The idea is restoring a pulse right in the foot gives the best chance of healing the forefoot. Plus, pedal arteries are often easier to get to surgically than the deep peroneal.
Okay.
However, if the peroneal artery looks good on the angiogram and seems to have decent collateral connections feeding the foot, a shorter bypass to the peroneal might be chosen, especially if vein length is limited. If the peroneal doesn't look great, they'll likely aim for a tibial artery lower down near the ankle or a pedal artery, even if it means splicing pieces of vein together to get enough length.
So it's really about balancing vein availability, target artery quality, and getting flow to where it's needed most, especially if there's tissue loss.
Exactly. It's a complex calculation tailored to each patient.
Now, physically getting to these arteries involves different surgical cuts or exposures. The chapter mentions standard and alternative approaches.
Yes, having a solid knowledge of anatomy and being skilled in various approaches is vital. The standard way to get to the femoral arteries in the groin is a vertical incision.
That's the usual way.
Usually, but sometimes. Maybe if the patient has had surgery there before, or if there's infection, or they need to reach a specific part of the profunda artery. They might use alternative approaches from the side, or the front inside, or even the back of the thigh.
Why would they do that?
These alternatives can be really helpful if there's a lot of scar tissue in the groin, hostile groin, they sometimes call it, or if the vein they have is a bit short and they need to start the bypass from a slightly different spot. But if they use these other approaches, they need to be sure the arteries above that point are clear.
Right, don't want to start the bypass below another blockage. What about accessing the arteries below the knee?
Usually they use incisions on the inside, the medial side of the leg, to get to the popliteal and the upper parts of the tibial and peroneal arteries. Often this incision is just extended from where they harvested the saphenous vein. Yeah, sometimes approaches from the outside, the lateral side, are needed. Getting to the distal peroneal artery way down low often involves an incision over the fibula bone on the outside of the leg, and sometimes they even have to remove a small piece of the fibula to expose the artery.
Wow.
And they also mention posterior approaches going in from the back of the leg. This can be useful if the target is the lower posterior tibial or peroneal artery, and maybe the small saphenous vein, which runs up the back of the calf, is the best conduit available. You can even do the whole surgery with the patient lying face down.
So lots of options depending on the target and the vein. They also mentioned using a tourniquet sometimes.
Yes, particularly if the arteries down in the calf are really heavily calcified, a pneumatic tourniquet can sometimes help control bleeding during the delicate sewing parts.
Okay, it sounds like surgeons need a big toolbox of approaches. Let's circle back to the conduit again. Vein is best, we established that. What if there just isn't any good autogenous vein? What are the prosthetic options, the artificial grafts?
If a thorough search really turns up nothing suitable, then yes, they have to consider prosthetic grafts. The most commonly used one for leg bypasses is PIS-TFE polytetrafluoroethylene. It's a type of plastic.
PTFE.
Dacron is another material also used. The chapter suggests maybe it performs similarly to PTFE for bypasses that don't go below the knee. There was some hope for heparin-bonded Dacron initially.
Heparin bonded, so it has a blood thinner attached.
Right. Early results looked promising compared to PTFE above the knee, but that advantage didn't seem to hold up over longer follow-up times, unfortunately.
So the message remains, prosthetics are second best of vein.
Definitely. And the chapter brings up something important for when prosthetics are used below the knee. Vein cuffs.
Vein cuffs, what are those?
It's a small segment of vein that's sewn onto the end of the prosthetic graft, right where it connects to the artery below the knee. It acts like a little transition piece.
And does that help?
Significantly, yes. Studies show these vein cuffs dramatically improve how long PTFE grafts stay open below the knee and also improve limb salvage rates. They mention a few specific techniques: Miller cuff, Taylor patch, St. Mary's boot.
But still not as good as a full vein bypass.
Correct. Even with a cuff, the results with PTFE below the knee don't match what you get with a good vein graft. It just reinforces that all-autogenous goal.
What about human umbilical vein that was mentioned?
Less common now.
Ah,
The chapter notes it can be harder to handle surgically, and there were some concerns about it developing aneurysms or weak spots later on. Some surgeons tried using it with a special connection to a vein, an AV fistula, to boost flow.
did that work?
A randomized trial didn't show a benefit for adding that fistula when using umbilical vein with a cuff for bypasses below the popliteal artery.
Okay. And heparin-bonded PTFE, is that a newer thing?
It is heparin chemically bonded to the PTFE graft itself. The idea is to reduce clotting right on the graft surface, especially early on, without needing systemic anticoagulation. Lab studies look promising.
But in practice?
It seems to reduce early platelet and fibrin buildup in animal models, maybe for a few months. It's an option, but still relatively new, and needs more long-term human data to see if it makes a big difference compared to standard PTFE, especially with the vein cuff.
So lots of effort trying to improve prosthetics, but vein still rules. The outline mentioned a table comparing grafts.
Yes, Table 112.1 summarizes the evidence. Key takeaway: vein beats prosthetics, even above the knee. Below the knee, if you absolutely have to use prosthetic, PTFE with some kind of vein cuff or patch at the distal end is the recommended approach. There's not enough data yet to say for sure if the newer modified PTFEs are truly better than standard PTFE with a cuff.
Vein is king. Got it. Now, using the vein itself, are there different ways surgeons handle it during the bypass? Reversed, non-reversed, in situ?
Right. The chapter says all three methods, reversed, non-reversed, and in situ, seem to provide pretty similar long-term results. The choice often depends on the specific vein available, the patient's anatomy, and what the surgeon is most comfortable and experienced with.
Can you quickly explain the difference?
Sure. Reverse vein is simple. You take the vein out, flip it end for end so the valves inside don't block flow, tie off the side branches, prepare it, and sew it in.
Okay.
In situ means you leave the vein mostly in its original place in the leg. You have to deal with the valves, though cut them with special tools called valvulotomes so blood can flow down. You also have to find and tie off all the little side branches that connect to other veins.
Why do in situ?
Proponents say it might give a better size match between the vein and the artery, especially at the lower end. Non-reversed is similar to reversed, but you still have to deal with the valves.
What about arm veins? Are they handled differently?
Arm veins tend to be more fragile than leg veins, so they need extra gentle handling. You have to be meticulous tying off branches. They also sometimes have internal issues like webs or scarred valves, so the surgeons might use angioscopy, that little camera, to check the inside more carefully. But the overall message is, gentle handling and precise technique are crucial no matter which vein or method you use.
Okay, so the bypass is sewn in. How do they check their work right there on the table?
Intraoperative assessment is vital. Right after the connections are made, the surgeon will feel the pulse in the graft, listen with a handheld Doppler, and visually inspect everything.
Looking well.
Good strong pulse, good Doppler signal. They mentioned an interesting sign. If you compress the graft downstream, but still feel continuous flow coming out, that might mean there's an accidental connection to a vein, an AV fistula, that needs to be found and tied off.
A real-time check. But the outline also mentioned more formal completion studies. What are those about?
These are specific tests done during the operation before closing to catch any potential problems that might threaten the bypass early on. Things like kinks in the graft, technical errors at the sewing lines, missed valve cusps in an in situ graft, problems in the tunnel the graft runs through, poor outflow, or even early clot formation.
Better to find it now than later.
Absolutely. The chapter says the best time to fix these issues is right then and there. There are four main tools they use: Doppler assessment, which they always do, intraoperative arteriography, intraoperative duplex ultrasound, and angioscopy.
Okay, we know Doppler confirms flow. What about intraoperative arteriography? X-rays with dye again.
Exactly. For reverse vein grafts especially, this is often seen as the simplest and most effective way. You inject dye, take x-rays, and you can see the whole graft, the tunnel, the connections, and the runoff arteries downstream.
And does it make a difference?
Studies show it makes a big difference. Routine completion angiography finds significant correctable problems in a surprising number of cases, problems you wouldn't just feel or see. Fixing those definitely improves long-term patency. The only caveat is it might not be the best for spotting subtle valve issues in situ grafts.
What about intraoperative duplex? Using ultrasound during the surgery?
Yes. This is particularly useful for in situ grafts because it lets the surgeon directly visualize the inside of the vein and look for areas where flow speeds up suddenly that indicates a narrowing or maybe an incompletely cut valve. It needs the right equipment and expertise, so maybe not as common as angiography, but very valuable in complex cases or when using arm veins.
And angioscopy, the camera inside.
Right. Great for directly looking inside, especially arm veins, which can have more hidden flaws. It's also excellent for confirming that all the valves are fully lysed in an in situ bypass. It can sometimes help upgrade a vein that might have otherwise seemed borderline by allowing targeted fixes. Some use it to help guide minimally invasive in situ procedures too.
So a combination approach often makes sense. Doppler always, then maybe angiography, with duplex or angioscopy added for specific situations like in situ or arm vein grafts.
That seems to be the recommendation, yeah? Especially maybe now, as the chapter hints, when surgeons might be doing fewer open bypasses overall, ensuring each one is technically perfect becomes even more critical.
Makes sense.
Yeah.
Okay, after all this planning and careful work, what are the results like? How successful is infrainguinal bypass?
Well, outcomes are tracked using standard definitions from the Society for Vascular Surgery. You look at objective things like graft patency, does it stay open? Limb salvage, did we save the leg? And mortality, did the patient survive the surgery and recovery?
Okay, the hard numbers.
Right. But increasingly, there's focus on subjective outcomes too. Durability over the long haul, functional outcome, can the patient actually walk better, live independently, and their overall quality of life.
Let's talk patency first. There are different types. Primary, assisted primary, secondary.
Good question. Primary patency means the graft stays open continuously, no interventions needed on the graft itself. Assisted primary means maybe an intervention like a balloon angioplasty or a small surgical revision was needed to keep it open, but it never fully clotted off. Secondary patency means it did clot off at some point, but they were able to successfully reopen it.
Which ones matter most?
Primary and assisted primary are generally seen as the most meaningful indicators of the bypass's ongoing success.
And how do the different graft types compare on patency?
As we've said, trials show in situ and reverse vein grafts perform about the same long term. And both vein techniques consistently outperform all prosthetic grafts, even above the knee. The chapter has tables and figures showing the expected patency rates depending on the graft type, where it goes, and whether it was done for claudication or the more severe CLTI.
So vein lasts longer. What about durability overall? Any other insights?
The basal trial provided some key insights here. It suggested that for patients who live at least 2 years after their procedure for severe limb ischemia, those initially randomized to bypass surgery actually had better overall survival and tended to have better amputation-free survival compared to those initially treated with endovascular therapy.
Interesting. So bypass might be better long-term for some.
It suggests that, yes, basal also clearly showed worse amputation-free survival for patients who got prosthetic grafts compared to vein. And another finding, patients who had a failed angioplasty before getting a bypass generally did worse than those who got bypass as their first treatment.
That really highlights the importance of that first choice, especially the conduit. What about functional outcomes? Can people actually live better after this?
That's the goal, but it can be challenging, especially for CLTI patients who often have many other health problems. The ideal outcome, open graft, healed wounds, no more surgery, independent living, walking well, isn't always achieved.
What predicts success functionally?
How independent and mobile the patient was before the surgery is a big predictor. Unfortunately, the chapter notes that reoperations and hospital readmissions in the first few months after bypass for CLTI aren't uncommon. Wound healing can also be very slow, especially with tissue loss, kidney disease, or diabetes.
So managing expectations is important.
Very. There's a push towards using more objective performance goals, considering both the patient's starting point and the results achieved. And definitely a need for more studies comparing bypass to endovascular or even primary amputation in high-risk patients, specifically looking at these functional and patient-reported outcomes.
Get the whole picture, not just the plumbing fix. What about cost and identifying high-risk patients?
On cost, the chapter mentions that while endovascular might seem cheaper initially for severe limb ischemia, that cost advantage often disappears after about a year because those patients tend to need more repeat procedures compared to bypass patients.
Interesting. And risk scores.
Several scoring systems exist, leg score, prevent 3 score, etc., to help predict who might do well or poorly after bypass. They factor in things like walking ability, diabetes, kidney function, ischemia severity. Unsurprisingly, having multiple comorbidities significantly increases the risk of bypass failure and other complications.
And quality of life. Does bypass help people feel better?
Definitely. CLTI massively impacts quality of life, and a successful bypass can bring significant improvement. But, crucially, keeping that graft open, especially in the first year or two, is key to maintaining that improved quality of life.
Makes sense. Graft failure or needing more procedures would set you back.
Exactly. Tissue loss and graft problems negatively impact quality of life. And again, the longer-term basal data suggest bypass might offer better amputation-free survival and lower mortality compared to angioplasty for many CLTI patients. This could actually be shifting things back towards considering bypass more strongly for relatively fit CLTI patients who have good vein and are expected to live more than a couple of years.
Fascinating how the evidence evolves. Okay, surgery's done, hopefully successfully. What happens next? Postoperative management.
Keep taking the regular meds for heart, blood pressure, lungs, etc. Be careful with fluids in heart failure patients. Continue beta blockers if they were started. Antiplatelet therapy is usually essential, typically aspirin. It helps keep the graft open and protects the heart.
What about stronger blood thinners, anticoagulants like warfarin?
The evidence isn't strong enough to recommend routine anticoagulation for everyone after leg bypass. Some studies hinted at benefits for vein grafts with certain drugs, but often with more bleeding risk. So it's usually selective. Aspirin is standard. Anticoagulation might be considered for higher risk grafts like a prosthetic below the knee, or if the outflow arteries aren't great, or in redo surgeries, or if the vein used wasn't ideal quality.
A tailored approach. And wound care.
Absolutely vital, especially in CLTI patients with existing ulcers or previous minor amputations. Need to prevent new pressure sores and help everything heal. Sometimes they even wait a few days after the bypass, once blood flow is restored, before doing major wound cleanups or formal amputations to give the tissues the best chance.
Good point. Let the improved circulation help first. Now, complications. What can go wrong?
Early on, things like wound infections, bleeding, the graft clotting off suddenly, graft infection, or even death, sadly. The PREVENT-3 trial data gives realistic numbers for these. Later on, you might see persistent leg swelling, lymphedema, late graft infections, the graft developing a weak spot, aneurysm, or a narrowing stenosis developing within the graft over time.
What if the graft does clot off? Early or late?
Early occlusion right after surgery is an emergency.
Mm-hmm.
You need to figure out why and fix it. Take the patient back to the OR, find the clot, remove it, thrombectomy, look for the cause, a kink, a bad connection, poor vein quality, bad outflow, and repair it. If the vein was really marginal, might even need to replace the graft.
And if it clots off months or years later?
You'd treat it if the patient is having significant symptoms again. Trying to dissolve the clot thrombolysis or use devices to remove it might be attempted, but success rates aren't always great for late occlusions. Often the best option is a whole new bypass, preferably with vein if available. If not, maybe another PTFE graft with a vein patch. But the best strategy is prevention.
Which brings us to graft surveillance.
Exactly. The chapter calls this critical for long-term vein graft success. Vein grafts over time can develop narrowings, usually from scar tissue buildup called intimal hyperplasia early on, or from disease progressing in the arteries above or below the graft later.
So how do they watch for this?
With a routine surveillance program. Usually involves checking the ankle brachial index, ABI, that blood pressure comparison, and doing regular duplex ultrasound scans of the graft itself.
How often?
Typically an initial check within a month, then maybe every 3 months for the first year, every 6 months for the next 2 years, then yearly after that, as long as it's working well.
And if they find a problem on the scan?
If they see a significant narrowing, usually defined by how fast the blood flows through that spot on the ultrasound, they'll often intervene proactively before it clots off completely. If the ABI drops or flow slows down without an obvious spot, they'll investigate further too.
Does this surveillance actually work? Does it improve results?
Yes. Multiple studies, including a randomized trial, show that this kind of program improves long-term vein graft patency by about 15% or so. It's considered cost-effective for vein grafts. Interestingly, it doesn't seem to offer the same benefit for prosthetic grafts.
So really key for keeping those vein bypasses working. If surveillance does find a stenosis, a narrowing in a vein graft, what can they do?
Often these stenosis are focal, just in one spot. Treatment depends on how long the narrowing is when it happens, early versus late, and the patient's overall health. For later, shorter narrowings, angioplasty, PTA, with a balloon is often tried first, maybe using special cutting or scoring balloons.
Does that work well?
It can, but the narrowing might come back more often than with open surgery. Sometimes stents are placed. Open surgical repair is another option. They might cut out the bad section and put in a small piece of vein, or if it's less severe, just sew on a patch of vein to widen it, vein patch angioplasty. If it's near a connection, they might revise the connection or do a patch. And they always check their work with imaging afterwards. If the disease downstream has progressed, they might need a new, longer jump graft.
Lots of ways to try and salvage a failing graft. The outline mentioned an algorithm in the chapter.
Yeah, it's basically a flow chart summarizing the whole process we've talked about. Preoperative strategy, intraoperative decision-making and troubleshooting, conduit choice, completion studies, post-op care, and the long-term surveillance. It really reinforces that proactive plan for problems approach.
A useful visual summary. And finally, key references. Any standout studies the chapter highlights?
Definitely. Basal, as we mentioned, comparing bypass and endovascular. Prevents 3, important even though the drug didn't work, taught us a lot about vein graft failure. The Global Vascular Guidelines for CLTI. A key paper by Ferry is showing arm vein works when leg vein isn't available. Work by Mills on understanding vein graft failure modes and the importance of surveillance. The WIFI classification paper. The Stonebridge study showing vein cuffs help prosthetic grafts below the knee. These have all really shaped the field.
That's a great wrap-up of the research underpinning all this. So, pulling it all together, infrainguinal bypass is a major tool for restoring blood flow in severe leg artery disease, whether it's CLTI or really disabling claudication.
And autogenous vein is, without a doubt, the best conduit. Careful planning, meticulous surgery, and vigilant follow-up with surveillance are all absolutely key for success.
Something that really struck me was that finding about bypasses to isolated popliteal segments working surprisingly well. It shows how adaptable the circulation can be sometimes.
It does. Collateral pathways can be quite effective.
So for you listening, we hope this deep dive gives you a much richer understanding of what infrainguinal bypass entails, way beyond just the definition. And here's a final thought to chew on. We see endovascular treatments evolving so rapidly. Where do you think open bypass fits in the future? Especially given what we've learned about the long-term durability of vein grafts. Or perhaps, what questions does this raise for you about that constant balancing act between surgery, less invasive procedures, and medical management for peripheral artery disease?
Those are the big questions, absolutely. Balancing the options, considering the long-term data, and tailoring it all to the individual patient. That's the ongoing challenge in evolution in vascular care.
Thank you for joining us for this deep dive into infrainguinal bypass. We really hope you found it insightful.